actually I am today, I owe a lot to that individual. But then science moves on, and I guess that's how with every generation progress comes about. And it's just that today we are on the threshold of, we have made a lot of benchmarks in pediatric cardiac surgery in India today, and neonatal cardiac surgery has become pretty commonplace, and it's become very popular. Excellent results are being produced in this country, more matching Western standards now. Good centers have come about, and corporates have gone into funding for pediatric cardiac surgery now. So in the last 10 to 15 years, it's been an explosion for the specialty. And as I can see, Dr. Rajan, who is there, and myself, we were all colleagues when Madras Medical Mission started. And from the team which we were working, I can see Dr. Robert in the audience, who is one of the newer generation of pediatric cardiac surgeons, who has taken over. And I'm sure this generation will push things further in the years to come. And it's indeed a heartening thought that we are having a website of this sort to further propagate the Indian scenario of pediatric cardiac surgery and cardiology, of course. They go hand in hand. And I think the efforts of Dr. Raghavan needs to be applauded, and I'm sure in the years to come we will be interacting with the world through this website. Thank you very much.
And now Dr. Srimati will introduce Dr. K.R. Balakrishnan.
I must introduce Dr. K.R. Balakrishnan to this audience. Many of you know him. I have known him for a very long time, from the time he was a postgraduate. I have watched him grow. He had been abroad. He had worked with Star, and he had acquired a lot of surgical techniques. Along with that, a desire to do more and more, work more and more on the research side. Funny that a cardiac surgeon should have developed this idea, but even today, he does that. One of the very few cardiac surgeons with a research-oriented approach to any of the problems. He has acquired, shall I say, he has acquired an acceptance from the public about his skill. And that has carried him along from hospitals to hospital. And this quality really stands him, and he would be delivering the second Sudha Memorial Oration. You would have heard the talk earlier of speakers about how pediatric cardiology began. We have reached the stage. Dr. Prem Shekhar from Frontier Line, his presentation. This has gone on the website. Similarly, anyone who's interested can launch their work on this website.
Dignitaries, desires, distinguished professors, ladies and gentlemen. At the outset, I'd like to thank the organizers and of the meeting, and in particular Dr. Srimati, for this great honor of giving this oration today. When Dr. Srimati requested me, asked me whether I could give this talk, she said, keep it short and sweet. I don't know what a sweet for, but I should certainly keep it short. Since it's a mixed audience and it has a certain topicality to this, I thought in the next few minutes I should speak about tackling the burden of heart disease in children. It's a especially great challenge to developing economies, not only in this country but all the countries which surround us and large parts of Africa. In fact, If you look at world literature, it's dominated by Western Europe and North America, and to a large extent, results, costing, standards, outcomes, risk stratification, everything is North American and Western European. And to a great extent, may or may not necessarily have great applicability, or even if it has to come as writers, because we practice in a different continent and different planet altogether in a lot of respects. And the economic challenge is one of the biggest challenges to overcome, especially in a complex specialty like pediatric heart surgery. If you look at heart disease in children, it's not just congenital heart defects. You also have a big burden of rheumatic heart disease, which continues to plague children, not only in India but a whole lot of developing world. You have myocarditis, which may not really come under the category of cardiac surgical units or cardiology units. But if you go to children's hospitals, especially during monsoon time, very large number of deaths continue to occur on previously healthy children from myocarditis because of viral and other etiologies. And of course, there are cardiomyopathies which lead these children to present with heart failure, which increasingly has more and more therapeutic options, which are very sophisticated and expensive, but they are life-saving. And if we are in this country not going to be left behind, we need to look at how we are going to be able to afford them for our population. Next slide. We don't know very much about why heart defects happen, birth defects, though I shall come to that in the later part. There have been some very exciting new advances in the last couple of years. The heart is one of the first organs to form, and due to events during heart development, often occurring even before the woman is aware that she is pregnant, these defects happen. Next slide. And except for some viral illnesses in mothers and a few known genetic defects, most of the time we don't really know why this happens. And it occurs in a little less than 1% of all births. The figures are surprisingly similar across continents and across ethnic races, and anywhere from 6 to 8 or 9 per thousand live births. Some of them are simple, some of them are complex, while 1/3 of them are serious enough for the babies to require some kind of treatment soon after birth, otherwise they will die. At a very conservative estimate, 150,000 to 200,000 babies are born in this country every year. And I think in the state of Tamil Nadu alone, I think it's closer to 15,000 babies every year. It's a large number added to the existing pool of patients already alive, adding to a huge burden if they are untreated. Next slide. Coming to rheumatic fever, these are fairly recent numbers. The incidence of rheumatic fever per 100,000 population in the United States is 5, and the developing world, of which we should be 1, is 20 times more. And next slide. The incidence of rheumatic heart disease per 1,000 population, which is last year's publication. The United States has 0.6 per 1,000 population. I would assume these are burned out cases from 2 or 3 decades ago or 4 decades ago. India has, again, 10 times more, around 11. In fact, there's one paper which from Uttar Pradesh where they found an incidence of 21 per 1,000 population of established rheumatic heart disease. And the scenario is pretty much the same across Asia and Africa. This is something I want to share. Those of the physicians in the audience will appreciate the irony of this. Rheumatic fever and rheumatic heart disease were unknown in India in the first 3 decades of the last century. Apparently, a professor of pathology in Calcutta Medical College called Rogers did not find a single case of rheumatic carditis or rheumatic heart disease amongst 4,800 postmortem records of 37 years. This is Journal of Associate Physicians of India, June 2006. So one would presume that with overcrowding and more urbanization of the population, we started seeing a disease which is so lethal now that it's worse than malignancy, in my opinion, to have a young child of 10 or 12 years with rheumatic involvement of multiple valves. It's a deadly disease. To give you a perspective, we listened to pioneers and what was possible. It's a very brief slide, it's not a technical talk. to tell you the current results are by and large excellent worldwide, including in this country. That's a picture of a newborn child. We had a transposition and until it switched on. He's now school-going boy. Next slide. And this child had transposition repaired using what we call a Senning procedure, and he's now a table tennis champion in a neighboring state in junior level. Next slide. And I'm particularly proud of this girl because she had again a newborn transposition. She now is in the research team designing unmanned spy surveillance aircrafts. So these are the possibilities if you're able to access good health care and apply modern treatment. But is it possible for everyone in this country to do so, or in the developing world? I don't think so, because what we treat is a very, very tiny fraction of the need because of a variety of reasons. Next slide. The reality of the Indian scenario, and this is true for not necessarily pediatric cardiac surgery, it's true for every kind of health need, is if you look at those three big circles, there's a need, there's an affordability, and there's a facility. And all three need to meet, and they seem to meet in a very tiny central portion. And that's the segment everyone is chasing for. I mean, the rest of it is unaddressed to a very large extent. Next slide. And what's the probability of getting treated even in the year 2009? Number 1, 2, 3, 4, 5, 6, 7, 8 would be affordability. Availability of resources, because there are several states where resources are not available, even if somebody were to be in a position to pay for it. If you're born in several of the states where resources are poor, it's very unlikely that you'll be referred or be able to get treatment. It's also a great paradox that in big metropolitan cities like here, we seem to have excess capacity in a lot of private hospitals where you have so many new hospitals coming up with cath labs and intensive care units where the capacity is excess. And yet, you have a large number of patients who need those capacities to be treated, and the two are not able to meet. So this is a logistics nightmare, and some of the newer developments in the state, I think, are trying to address those issues. Next slide. The Indian reality is the affordability is poor, but then when you say affordability is a relative term, poverty is a relative term, illness can make anyone poor. I mean, I don't know how many of you had the opportunity to see this movie called Sicko by this guy called Moore, who made the movie Fahrenheit 9/11. It's a take on the American, the French, and the British health system. I think it should be mandatory viewing for almost everyone who's even remotely connected with the health profession, because it makes a very interesting insight into how health systems across the countries work. And we seem to follow the American system in terms of essentially private-driven healthcare. And what's frightening is how easy it is for a middle-class family to become very poor when major illness strikes any member of the family. And it's a reality in our day-to-day world as well. Next slide. Things like artificial heart or transplantation, all kinds of technologies are possible and in fact exist in this country today. But then again, is it universally accessible? I don't think so. Next slide. So this is a slide which I took from Journal of Thoracic and Cardiovascular Surgery. This is again not to impose too much of technical jargon, but just to highlight, it's one of the few papers that I found which looked at costing of surgery as an issue and published in a scientific publication. And they looked at 3 common operations that we do all the time. One is closure of an atrial septal defect, which for the doctors in the audience will know is one of the simplest and most commonly performed procedures in pediatric cardiology. The next is the ventricular septal defect, and the third is commonly done to Charlie Fellow or Blue Baby. Next slide. They found that this was a study looking at the cost incurred in doing these procedures, and they found that if you look at the variation in cost in terms of standard deviation, it was least for atrial septal defect, which you would imagine because it's a simple operation, which is maximum for Charlie Fellow because it's a more complex procedure. Next slide. And then they looked at the cost of doing, say, a very simple operation to call VAT closure. And two things are striking. One is the cost is not uniform for all comers. It depends upon a whole lot of factors which are variables. Number two is the minimum cost is $25,000 to $30,000. Next slide. And this is again risk stratification, not in terms of outcomes, because outcomes today are good even in this country. But the price we pay for those outcomes is very, very different, and that's a huge burden for those in any system, in the government system or the private system, because at the end of the day, when a patient is going home and the bill is 3 times more than he bargained for or he was told, it's a very unpleasant situation. The hospital is not happy, the patient is not happy, and somehow it seems to be the doctor's fault. And it does not necessarily so. Next slide. And to tell you further again, the degree of variation in cost is from $39,000 to $175,000 for the same operation, for the same good outcome, depending upon variables, preoperative and intraoperative factors. Next slide. And next slide. Now, this has a great topical relevance because this was first started in the state of Andhra Pradesh. Now, in our state, we are having, in my opinion, a very exciting situation where the state is funding for a large number of children who are born of parents below the poverty line, and now I'm told that the new insurance scheme for adults is going to be launched day after tomorrow. Now, I'm not sure how much of scientific inquiry has gone into the funds which are being allocated for each of these operations. To give you an example, for a ventricular septal defect, the state of Tamil Nadu gives 50,000 rupees. I mean, 50,000 rupees is not a small amount of money, but it's not a huge amount of money. But it's very difficult to necessarily treat all comers with that price, because especially if you look at the data that I showed, it's not even 100th of what it will cost in the developing country. Even if you take all other factors into consideration, each child, each adult cannot be one slot. So we need to have a lot more scientific valid data from a whole lot of other centers in this country if we're going to move forward and start calling ourselves more developed than we are currently, instead of wallowing in poverty. Next slide. Now, if you look at the reason why the Indian cost typically are 1/10 to 1/20th lower than the Western figures, and as Dr. Suresh said, currently the results might be very good. And so, if we are able to get those results at 1/20th or 1/30th the cost, we must be very clever. But have we analyzed as to why the cost is low? And I'm not sure I haven't come across any scientific study looking at costing from an Indian perspective. It would be a very good subject for one of these MBAs from Miami to do it. First, almost certainly it's due to lower personnel cost. I mean, the salaries of all the people involved in providing healthcare is far, far lower than the European or American counterpart. Of that there's very little doubt. The pharmacy costs are incredibly low in India as compared to the Western world, even neighboring countries like Sri Lanka or Bangladesh. The other point, the malpractice insurance costs are almost negligible in this country as compared to anywhere else. Apart from all this, we also have a great tendency to reuse some of the disposable items, which people are forced to do because of the cost. But increasingly, I think legislation is being brought in to avoid that. Then reuse is incompatible with low cost. I mean, non-reuse is so those are issues to be sorted out. But on the other side, it's a very high real estate cost. If any private hospital which starts in the heart of the city, the biggest cost incurred, if you speak to the owners, is the cost that they pay for the land and the building. That's what leads them to charge as high as whatever they do. Next slide. So how do we go about reconciling all this? First is, one of the striking features of this, those of you who are from this state who practice heart disease will